Thank you very much, Dr. Janaka Peiris, consultant neurologist. I'm just wondering what should I do right now? We have done everything. Yeah. Actually, vertigo is a symptom, as you very correctly mentioned. And to understand vertigo, in my perspective, I would rather like to say how do we maintain our balance? It's a continuous reflex mechanism. It had been happening right from the 6 weeks of our life. Depend on the gravity sensation, the visual input, the somatosensory inputs, the vestibular system. So it's like almost every moment we are falling, that is being corrected with this balance mechanism. So it is a kind of a symmetrical right and left is organ, the vestibular system working together. For example, if I'm turning my head to right side, there will be positive impulse from the right vestibular lateral semicircular canal and the negative one. The brain as like a CPU, processor, it will interpret that and accordingly maintain the visual focus as well as bodily posture, not to fall, but not to get any, moving object. Still we can focus. So as very correctly Dr. Janaka mentioned that the Ben's advertisements, you would have understood that how we maintain the focusing our vision. Nowadays, of course, young crowd must be aware there's a special camera gadget you can fix if you want to take a good quality video, what you call gimbal. Now, if you are just recording with the camera, if you are moving, you are going to get kind of a, lines like picture. But with a gimbal, you can play around and you have a static picture. Very expensive gadget anyway. So now, as everything almost covered, my job is to touch up here and there. So as an ENT surgeon, patients themselves come to us and we get a lot of referrals. So first of, when we get a patient with acute vertiginous attack, acute symptomatic patient, first objective is to differentiate whether actually is this a peripheral vertigo or a central vertigo, because it is not our duty to cross the central part. He is there to deal with. So that is a big task actually, because during my lecture I might try to not to offend anything. I will talk about some negative things what is happening, like just the Stemetil being prescribed for years and years. They are coming with extrapyramidal symptoms, and the beta histidine prescribed for years. They are empty pocket because they're very expensive medicine. So as a learning point, what I'm trying to highlight here, an acute vertiginous patients very, they are very symptomatic. The autonomic nerve system very agitated, vomiting, sweating. They have got, blood pressure shooting up, and all the, relatives are excited. So doctor, do something. So sometimes we also rush to do MRI scanning, and So the question, if we have a method to screen them out, narrow them out, whether very in a quick manner. I think already our neurologist mentioned about, we call it HINT test. The head impulse test, nystagmus, and the test of skew. So if you are aware about all these things, even as a house officer, anybody, any medical grade person should be able to practice this. I would say more than 50% you will be able to screen out whether it is central or peripheral. Now, in this here, what we are trying to say that just arm's breadth distance, we are keeping the patient, ask the patient to hold the patient's face with the two hands, and ask the patient to focus on your nose. Then we are just rotating. Firstly, don't just start with, just let them to, just relax the neck muscles. Otherwise, excited patient might get a neck injury. You slowly move a couple of times, then you start doing this. Yeah, you can see what is happening to the eyes. Keep on focusing on the eyes. Right eye, normally I should be able to keep on focusing. But what happened, it went away and came back. Kind of a saccade of movement happened. Already this was discussed by our neurologist as well. This is head impulse test positive. Now, nystagmus, there are various reasons due to have, ocular, vestibular reflex. There's something wrong. It's like knee jerk. It's a normal thing, but you know how to interpret abnormal. So now here you can see the right hand side picture. The nystagmus is kind of a vertical one. If I happen to see this, I want to touch that patient, I'm more than happy to hand over to neurology department. The other nystagmus you can see, kind of a horizontal and a fast component, and also slow component, and also twisting. So if you know these features, it's very much easy to identify what is the background situation. Now the final thing is the test of skew. The yellow round describe you're covering the patient's eye, ask the patient to look at your nose, and then you change it. Then see how it is, what is going to happen to the eye's focusing ability. Now you can see on the right hand side eye, while you covered, eye was lost its focus, it tend to come back to the focusing. So if this is positive, now if this is the situation, it's a very quick screening method, just hints test. You can come to a situation whether you are dealing with a peripheral cause or a central cause. And now, as very correctly our neurologist mentioned, at the very early stages of especially posterior cranial and brainstem infarction and all, before the MRI changes come in, you can even get positive hints. So you can interpret head impulse test, central lesion normal, peripheral lesion abnormal. Nystagmus is a kind of a direction changing or vertical, what you call direction preponderance. In peripheral, fast component, normal side. So if there's a fast and slow component, you can consider as a vestibular nystagmus. And the test of skew present in central lesion and it is absent in the peripheral lesion. Very quick test, even at A&E we can just perform rather than rushing the patient for an MRI scan. So I thought of just mentioning a few words about here as well, because sometimes you get the call from A&E department, the patient is vertigo, come and see. So by the time we are going to focus into the peripheral lesion which giving rise to vertigo, we would rather like to exclude these causes. Acute coronary syndrome, arrhythmias. Arrhythmias are very well known. A lot of patients come to me, then I thought of arrhythmias and ECG shown. Even I myself have diagnosed arrhythmias. They were coming with dizziness, not definite vertigo, but somehow other they were labeled as vertigo. It's an hallucination. So just keep in head, before concluding this is peripheral, just to exclude these things. Now, these are the most common peripheral causes. They are coming with acute symptoms, unilateral vestibulopathy, the strokes, the similar, they can have, same symptoms. Even in an acute attack of Meniere syndrome, they will be very aggressive, vomiting, they can't maintain their bodily posture. So in this sense, keeping all this in our head, we supposed to take a good history, onset of the symptoms, whether it is insidious, kind of a sudden onset, just you wake up early in the morning or late night, you feel everything is just swirling around your head. All these things are going to be very important. The time course also important. Is it worsening? I had very severe one, then it settled down. Whether it is persistent or it comes and goes with the head movement or body movement and the associated symptoms. Still, I'm going ahead with the history because sometimes patients, they just forgotten they had a small head injury, a small concussion. Now they try to isolate this symptom from that incident, but it is there. Even very recent upper respiratory tract infection can lead to peripheral vestibulopathy. So from ENT surgeon's perspectives, what our objective is, we are trying to elicit any deficit in the vestibular system. So we ENT surgeons, other than this the hint test, we try to do a test called the fistula test, where we keep the tragal cartilage, we just cover the external rotary canal very quickly and look for any abnormal movement, kind of a nystagmoid movement in the eyes. Because of the pressure changes, like we are doing a calorie test, if there's any abnormality, you will be able to see the movement. That, of course, it happens if there's an opening into the lateral semicircular canal into the middle ear, the pressure change can lead to vestibular nystagmus. Another test, we are not doing it very frequently if you are very doubtful. If the patient is okay, he doesn't have acute symptoms, but otherwise okay, but he described he had a very severe attack. Then what we're trying to isolate the visual input and also the somatosensory inputs by doing the Unterberger test. We ask them to keep the arms stretched out, eyes closed and start marching in the same place. We believe that by doing that, we are going to jam up the somatosensory input. Already eyes are closed. Then the person is supposed to maintain the balance purely on the vestibular system. If there's a discrepancy, if one side is not working properly or irritating, then what will happen? Patient start moving toward that side about 30 degrees. If it is an irritative lesion, we call it Unterberger positive. Then of course, all the other balance tests we should be doing to exclude any cerebellar lesions as well. Now, once the patient comes to us with a vertigo, ideally speaking, we should be able to do the video nystagmography. I think our neurologist showed some videos, and electronystagmography, and ocular, vestibular, evoked myogenic potentials, and the C-vamp and O-vamp, cervical. Where of course we are trying to elicit the cervical and utricle and sacral the reflexes. Actually, there's a like a EEG machine like gadget is there. We just to fix the electrode and we put the goggles and run the software. We get all the results. Very easy. I mean, it's an automated machine. Actually, we have one in Anuradhapura Hospital, but not in National Hospital Kandy. And of course, you would have seen once a patient referred to us with a vertigo, we always jump to go ahead and do a hearing assessment. We do pure tone audiometry, and occasionally, if we are thinking that going ahead with an MRI scanning going to be very time consuming, and if you are suspecting something retrocochlear lesion, we do what you call brain stem York response audiometry. So where we can identify if there's a retrocochlear lesion. The ECOG also as part of it, it is a kind of a diagnostic for the Meniere syndrome. When I discuss about these things, I'll go into more details. So finally, talking about the history and all these things, practical clinical classification of the peripheral vertigo. These days, even if you log on to the Cochrane and all, they talk about these things. If you describe acute vertigo for the first time, you can narrow down your diagnosis, single acute episode. Most probably it could be a vestibular neuritis, a stroke, TIA or trauma associated. And if it is acute headache of recurrent vertigo, then you have a list of some disease entities as well. Chronic vertigo, of course, we consider it's kind of a functional thing. Already our neurologist talked about it. Now I'm narrowing down to the peripheral vertigo, common things, the benign paroxysmal positional vertigo, and the vestibular neuritis and the Meniere syndrome. I'll try to elaborate on more on these things. Benign paroxysmal positional vertigo, of course, the pathophysiology is that we all know that there's a gelatinous material in the utricle and the sacule. The utricle gelatinous material, due to various reasons, degenerative conditions, trauma, viral infection, old age, they can just dislodge the tiny calcium carbonate particles and they start floating inside the endolymph. Then what will happen? While the patient is sleeping, with the gravity, they tend to gravitate onto the most dependent part, commonly the posterior semicircular canal. So when you try to move away from that side, you are going to get an abnormal signal into the brain. So then brain is going to feel that hallucination with a compensatory mechanism in the brainstem level and with the help of cerebellum that will just recover. So the symptom, the vertiginous feeling, going to last only for a few seconds. And it is not associated with any autonomic nerve system symptoms like vomiting, the sweating or anything as such. This principle is very important to understand because our treatment also there. But sometimes if it is chronic, other than the floating these canalith, the calcium carbonate particles, they can go and lodge or attach to the cupola. In the semicircular canal, you have ampulla, inside leaf-like, the gelatinous thing called cupola. That is the one feeling the inertia of the liquid. These particles can go and attach there. To dislodge them, it is little difficult, not like the one floating around. So if it is the case, if this is the pathophysiology, so then we should be able to do a bedside test and diagnose it. What do you call it? Dix-Hallpike test. Here in this picture you can see the red particles are the calcium carbonate particle. When the patient is lying down, you can see they start moving. So patient is developing downbeating, classical, the vestibular nystagmus. There's a fast component, twitching, like that. So what we're supposed to do, make the patient comfortable, seated on the table, not lying down, seated with the stretched legs, and hold the head, turn to, if you are testing on the right side of the ear, 45 degrees, then make the patient lie down. We'll have to keep the head even 30 degrees below the level of the bed. By doing that, we are going to stimulate the posterior semicircular canal particles to start moving with the help of the gravity. Then they will develop this classical vertigo. It is diagnostic, bedside, in only a couple of minutes or less than even a minute. You can confirm the diagnosis. They don't develop vertigo, anything else. I mean, the vomiting or anything, any severe symptoms. Only the vertigo. They get excited once they develop the vertigo. But then and there, if it is the case, the treatment also there. We proceed to do what you call Epley's manoeuvre. So what we are planning to do, let these particles to move away and get them back into the utricle. So in the picture you can see from position A to position B is the Dix-Hallpike test. From there onwards, we turn the head 90 degrees to the opposite side, and each step we'll have to wait till the nystagmus is disappeared, roughly about 30 seconds. Then finally you will be turning the head downwards, making the utricle get the calcium carbonate particles back. You can see in this video what is happening. That is Dix-Hallpike test. The particles are moving. You can see the nystagmus is there. In a matter of 30 seconds, it will fatigue or it will disappear. Then you turn the head to the opposite side. You can imagine what is happening in the semicircular canal. The particles are once again start moving. Patient is going to develop the nystagmus. Then finally, we make the patient to prone position. The utricles get into the canalith get into the utricle, and they make the patient to sit up and the head little bit flex forward. I mean, once you've done the Epley's manoeuvre, over the last 10 years, there had been so many arguments. You need to keep the patient in the bed, head up, and do so many, arguments saying that they might come back. But with the latest update, you can only advice you can give the patient is that not to keep the affected ear when you are sleeping on the underside, just to keep it onto the upper side, or sleep on the opposite side. That's a simple advice. Of course, the success rate. Now, here sometimes you have very obese patients. The patients are having some cervical, anomalies or something. You cannot move their head and all. Therefore, we have some different maneuvers, what you call Semont's manoeuvre, where even at home they can practice these things. The same principle, what you want, get this canaliculi to get back to the utricle. When you are doing these tests, the procedure, sometimes you lose these particles halfway, and they can get into the lateral semicircular canal. The patient was having posterior semicircular canal, the symptoms, now they are having lateral. In that situation, we will do another procedure called Gufoni's manoeuvre. Very simple. Sometimes I advise the patient how to do it at home by themselves. If they come back and say, no, I got once again some other symptom, those days when I was turning, I had the vertigo, now when I'm nodding my head, I'm getting it. Yeah, then do these tests. So normally, outcome and follow-up of the BPP patients, in the first repositioning manoeuvre, Epley's manoeuvre, success rate is about 70%. In about 2 weeks' time, normally we follow them up and repeat the procedure if they are symptomatic still. The success rate is about 95%. Pretty good. And still, if they are symptomatic, we recommend them vestibular exercises. At the end of my presentation, I'll be talking about. But there's no any place for any vestibular sedatives, beta-histine or anything. The sad part of it, by the time we get the patient, we have a diagnosis card saying BPPV, and the treatment, stemetil, beta-histine, sinerosine, flooded with lot of vestibular sedatives. So what will happen, even we can't elicit the Dix-Hallpike manoeuvre, even you can't elicit the nystagmus, because the nerves are not functioning at all. So the one request, if the patient is having episodic lasting for a short period, if the patient is not severely symptomatic, never ever start on vestibular sedatives without coming to a diagnosis. So without proper diagnosis, without doing the Dix-Hallpike maneuver, somebody writing down BPPV, I don't know how it came. It's not scientific. So the just in the picture you can see some patients, with the 5% of the patients, those who are not doing well with the even second attempt of Epley's menu, we recommend them random of exercises. I mean, I don't want to go into detail in the web, or there are so many YouTube videos. Anybody can just follow and learn those things. Now, second most commonest thing is the vestibular neuronitis. That can affect all age groups except in small children. It's present very acutely, spontaneous nystagmus, vertigo, nausea, very kind of a severely ill patient. Even they can't walk. Normally they will be helped by somebody. The good thing is about it also going to last maximum 3 to maximum 4 weeks. It's kind of a spontaneous result. So the question whether how are you going to diagnose vestibular neuronitis? To do that, you need to exclude all the other sinister conditions, especially the central nerve lesions. So by doing hint test at the beginning I mentioned about, if you exclude any positive skew or any central lesion suspected, suggestive type of a nystagmus, you won't diagnose vestibular neuronitis. You'll be going for imaging and referral for the special care, but otherwise you'll be diagnosing vestibular neuronitis. Then the question, there are some differential diagnoses you need to think about: an acute attack of migraines or acute attack of Meniere. So in migraine, you won't get nystagmus. Pretty simple. Migraine is basically, in my clinical practice, it's a by diagnosis by exclusion. By the time you excluded everything, you don't have anything, you can put the label vestibular migraine. And with regard to treatment, there had been attempts to give some antiviral because thinking it's a viral pathology there, and of course the steroid. So, but there are later studies proven that the duration of the symptoms going to be shortened by a short course of steroid. It could be even intratympanic, giving, you putting some steroid into the mid layer, which will then diffuse back through the round window into the inner ear, or else systemically, if it is not contraindicated. So you can understand the vestibular neuronitis and labyrinthitis. The labyrinthitis is an inflammation happening inside the membranous labyrinth. That means inner ear, not the vestibular nerve. In this situation, we just do a pure tone audiometry or just do the bedside hearing assessment. If there's a hearing loss or reduction on one side, that means it's highly unlikely to be a vestibular neuronitis unless a person who already had hearing loss. And now coming down to Meniere syndrome. The Meniere's disease, once again, about this nomenclature, there are so many arguments, because Prosper Meniere way back late 1880s described triad of symptoms: fullness of the ear, the vertigo, and the fluctuating hearing loss. But now we even say that even patient can have one or some or all the symptoms, still you can diagnose Meniere syndrome, because the principle of Meniere's, the disease or the syndrome is that endolymphatic HYDROPS. Because now from the stria vascularis, the inner ear blood supply, you produce the endolymph, which is being absorbed at the endolymphatic duct and the sac, which is opening into the subarachnoid space in the posterior cranial fossa. It's a dynamic process, a liquid being synthesized, secreted, there's a flow and then absorption. So any faulty thing happening in this dynamic process, you can end up with a pressure buildup like glaucoma. If the endolymphatic HYDROPS happen, then you can have cochlear symptoms because of the distension, which can damage even the hearing, and also because of the pressure buildup within the semicircular canals and utricle saccule, you can have these symptoms. The causes for endolymphatic HYDROPS, of course, there are a lot. We describe endolymphatic HYDROPS as a secondary to some other condition like diabetes mellitus, hypothyroidism, dyslipidemia, anything which can affect the microcirculation of the body. Even I had a couple of patients, those who are following chemotherapy. So, and I was wondering during COVID time, some patients who were referred with vertigo, I was wondering whether they were having endolymphatic HYDROPS, because it was affecting the microvasculature, arthritis and things like that. So if it is the case, all the causes of endolymphatic hydrops you can't put into one umbrella. In practical way, if you can't find any cause which should have precipitated endolymphatic hydrops, I mean it is idiopathic, there's no any reason, then you can label it as Meniere's disease. It may be allergy, it may be autoimmune, it may be familial. So if you find some other cause, we call it secondary endolymphatic hydrops. Because most of the time, once you control the primary cause, this Meniere's syndrome, the symptoms are also going to wane off. Otherwise, if you put the label Meniere's disease, it's a lifetime disease. You need to manage them. So that is what I want to highlight here. And now, in Meniere's syndrome or Meniere's disease, with the endolymphatic hydrops, we do hearing assessment. The earliest sign of Meniere's is that you can see on the left corner down, the low frequency of the left ear is affected. If in the cochlea, if you analyze the dynamics of the cochlea, the low frequency is heard at the apex of the cochlea. That is the place you will have the highest pressure. So that is the area going to affect. So you have a vertigo lasting more than 20 minutes, fullness, tinnitus, you do a pure tone audiometry, which is showing low frequency, the hearing impairment. Now you are narrowing down the diagnosis. And we used to do other tests to confirm like ECOG, electrocochleography, but nowadays, if it is very doubtful, if you are asking for an MRI, we can ask contrast MRI to analyze the inner ear, where the distended T2 enhanced the cochlear, the pathology is also detectable. That is the latest thing about the endolymphatic hydrops. So this is something very important because now I have had some patients those had been labeled as Meniere's syndrome, but later on they were having like some other neurological conditions, because as very correctly Dr. Janakveer mentioned, once you have the symptoms without coming to a diagnosis, somebody just putting them on a vestibular sedatives, you are just going to mask the symptoms. So we will never come to a diagnosis. So here what I am trying to highlight, in case you are going for an MRI scanning, better to look for the inner ear pathology as well. So now, how are you going to manage in the during the acute attacks? Of course, up to 5 to 7 days we can use vestibular sedatives because patient is suffering a lot. But beyond that, we can use micro vasodilators like beta-estine. Actually, we can start with higher dose, and then prophylactically you can make it smaller dosage. There's no any definite regime for the Meniere's syndrome management. We strongly advise them to go for a low salt diet, and during acute attacks sometimes we use the diuretics, even sometimes we use the IV vestibular sedatives, because if the endolymph pressure is too much, that can damage the membranous labyrinth, so which can finally lead to permanent hearing loss. To start with fluctuating hearing loss, if you don't bring that the unwanted pressure build up in the inner ear, which can lead to membranous damage, because the endolymph has a lot of potassium, the perilymph less potassium and more sodium. Once they mix up, they are going to damage the hair cells in the inner ear. So that's a permanent loss. So if you don't manage Meniere's syndrome properly, what will happen? In years' time, they will have a very agonizing, disturbing tinnitus, even they can't sleep, at the expense of hearing. So in other Western world, they even do cochlear implantation, which will improve the tinnitus and as well as the hearing. So coming down to, and also, I think already this part was discussed by Dr. Janakveer, so I don't want to waste any more time. The other causes of vertigo, common things is a bilateral vestibulopathy following trauma and also following medications, especially chemotherapy. Especially in small kids, they use a lot of gentamicin, neomycin, the aminoglycosides there are some, the vestibulopathies are there. Some are actually transient, but some are permanent. Few words about this superior canal dehiscence syndrome. It's a kind of a special ENT thing, but the presentation almost like BPPV. The treatment is surgery. Perilymph fistula, already I discussed at the beginning about the fistula test, that inner ear being exposed to the middle ear. then of course what we do, we'll have to go ahead with the surgery. There's no, all these patients that I'm mentioning here, by the time we diagnose, they had been flooded with so many vestibular sedatives. It's a single surgery, one session surgery should have saved that unwanted time, clinic visits, money and everything. And of course, this chronic suppurative otitis media, toxins, recurrent infection always lead to inner ear pathologies as well. Mind you that ear surgery also causes the vestibulopathies. Now, I think I had been trying to reiterate that to be careful about this the vestibular sedatives during an acute attacks, 5 to 7 days, yes, and then because we are not going to get the help of this central compensatory mechanism. It's like that. Now, motion sickness, some of you are having. So, how you get motion sickness? Assume you are traveling by a bus. Then what is happening with the gravity and movement? Your utricle and semicircular canals are functioning. But assume you are reading something, so that your visual input is not getting into the brain to say that you are moving. There's a kind of a jam up system, thing happening at the brainstem level. So that is why that hallucination you get. Then you will get autonomic nervous system stimulation and vomiting and all these things. So, but if you train yourself while you are traveling to look around and all, automatically the motion sickness will disappear. You don't need to take any sedatives. Same way, even if as you might have done some surgery and you had to sacrifice the inner ear, maybe cholesteatoma or tumor, within 2 weeks time we can bring them back to normal. The brain will look after the rest of the thing. With the one side they will maintain the balance. So vestibular sedatives without proper diagnosis is not advisable. It will prevent central compensatory mechanism. Of course, to improve the vestibular central compensatory mechanisms, there are some exercises. Actually, these are not being practiced in Sri Lanka, but in the Western, because of this geriatric medicine now developing on a very rapid state for the elderly care, there are a lot of exercise programs are happening. I think I'm almost finishing my time. I don't want to spend more time. Thank you very much for listening to me. And take home message, basic skills for any medical person is attainable easily. Hint test, this is what I'm talking about. And when to refer to neurology and ENT, now you can have an idea, listening to myself and our consultant neurologist, how are we going to help our patients rather than just starting on vestibular sedatives. And wisely use hints, that is what I want to highlight here. There are a lot of patients being referred or coming to me, they had already MRI, but they were actually having BPPV. I was just wondering like this. I wonder whether the radiology department's going to agree with me. We have a huge MRI waiting list. It takes 1 hour, contrast. Once you ask to do the brain imaging for to exclude any central lesion, you'll have to sit on it. But if you do proper skillful hint done, like few of our colleagues now enjoying the ride, we can make it very quick. Thank you very much.